All right. Good morning, everybody. My name is Eric Yen. I'm the Director of Marketing for Shield HealthCare. The webinar today is entitled Identifying Skin Damage, Pressure Ulcers versus Incontinence Associated Dermatitis. Your presenter today is Mary W. Sears. Listeners will be in a listen-only mode. If you have a question, please type it on the question box to the right-hand side of your screen. This presentation is being recorded, so if you missed any portion of this presentation, feel free to log into the community site at shieldhealthcare.com to catch up on any information that you missed. So again, your presenter today is Mary Sears. She's a graduate of the Kosler School of ET Nursing at the University of Southern California. Mary has earned well-deserved recognition for her expertise, including the Pacific Coast Region Wound Ostomy Incontinence Nurses Society ET Nurse of the Year in 1994, President's Award for Excellence in 2001, and Mentor of the Year in 2004. Mary served as a wound care specialist for Kendall Covidian and USA Convatec. She is currently a clinical consultant with Capital Nursing Education, and we are honored to have her speaking on behalf of Shield Healthcare today. So at this time, I'd like to pass the presentation over to Mary. Mary.
Thank you, Eric. Good morning, everyone, and welcome to our webinar today. On behalf of Shield and Capital Nursing Education, we're so glad that you could spend some time with us this morning. We are going to be studying skin damage as it relates to pressure ulcers versus incontinence associated dermatitis today. I would like to review with you quickly the objectives for today. Hold on just a moment. We're just having a little technical issue here getting our objectives up. Thank you. We're going to be looking at the difference between incontinence-associated dermatitis, which is a fairly new term to many, and pressure ulcers, looking at the effect of excessive moisture on skin integrity, and then what are the three main components of skincare regime that we can use to deal with people that have incontinence issues. Before we begin, let's take a few minutes to look at the anatomy of the skin. The skin is truly the largest organ of the body, and it is a multicellular system, very complex, composed of three layers: the epidermis, the outer layer, the dermis, and then the hypodermis, or the subcutaneous tissue under the dermis. The epidermis is really the protective barrier of the skin that keeps out organisms from the outside environment. It also aids in the synthesis of vitamin D, and we know that many people have vitamin D deficiencies today because of less time in the sun. It also contains the skin pigmentation. It's really composed of 5 layers, and it regenerates every 28 to 42 days. The dermis, the layer under that, is a thicker layer that's composed of many types of cells, but the fibroblasts are one of the main cells, and these are what synthesize and secrete the protein, collagen, and elastin. Of course, the role of collagen is to provide the tensile strength to the skin, while elastin provides for our skin to recoil. The epidermis also contains blood and lymphatic vessels, hair follicles, and sebaceous and sweat glands. So therefore, it provides blood, oxygen, and lubrication to the skin. The layer under the dermis is called the subcutaneous tissue, referred to more accurately as the hypodermis. It's really composed of connective tissue and fat, and its primary function is to store energy and to insulate the body. As we work with problems on the skin, we focus a lot at the pH of a healthy skin, and this should be between 5.5 and 5.9, which is mildly acidic. And this really causes the suppression of the coliform bacteria so that does not become an infectious state for the organism. The importance of the acid mantle is further of interest when we look at occlusion on the skin, because anytime the skin is occluded, this can result in increased in relative humidity, production of carbon dioxide, and a more alkaline pH. And all of these things place the skin at increased risk. When we look at the skin's natural moisture barrier, the moisture barrier of the skin is an essential component of skin integrity, because what it really does is it slows the movement of water from the body's interior and protects the body from excessive absorption of water and solutes from the environment. The moisture barrier consists of proteins that are found in the stratum corneum, or the outer layer of the epidermis. It functions to maintain the delicate balance of transepidermal water loss. This may be a new term to many, but that simply means that the body does not lose fluid that is internal, as well as it does not absorb a lot of fluid from the external environment. So you can see that if the skin barrier is disrupted, water loss occurs and bacterial invasion can occur. The corneocytes in the outer layer and the lipids are arranged in an interlock and stratified arrangement like bricks and mortar. If you look at the diagram on the right, I think that you can easily see that. And this is really, the lipid layer is really what slows the water loss from the subcutaneous space and impedes the absorption of water or other fluids that come in contact with the surface of the skin. Today, we are taking care of many more elderly patients, and we know that as the skin ages, there are several remarkable changes that occur in them. Many we can see with our eyes, and many are not as visible. There is certainly a decreased dermal thickness, so the skin really thins a lot. It becomes almost transparent. You can almost see through it. One of the major things is the flattening of the dermal-epidermal junction of the skin, and this allows the epidermis and the dermis to separate more easily. So the epidermis kind of really slides along on the dermis underneath. And this really increases the risk of injury. If you think about the elderly patients that you might have cared for and skin tears that frequently occur on the limbs or on the arms, all of this is because of that flattening of the dermal-epidermal junction. There is also decreased circulation and thinner blood vessels, so many times our elderly people are, because of the changes in thermoregulation, really chill more. They're more uncomfortable when the temperatures drop. And if there is any broken areas or any wounds that develop, they are at increased risk for slower wound healing because of the increased time that it really takes for the epidermal regeneration to occur. Let's look now. Oh, I'm sorry. I went the wrong way here. Let's look now at accurate skin assessment, and what are some of the things that really impact our practice as clinicians when we care for patients. One of the things that frequently happens is that if we are unfamiliar with various types of wounds that can occur, a lack of knowledge about the etiology of how the wound was formed and why it exists really leads to all open wounds being classified as pressure ulcers. And this can be a real issue in today's healthcare environment. It's particularly problematic because present on admission for pressure ulcers is such a critical consideration when looking at hospital reimbursement. Also, the financial implications can be staggering for an organization if it's found to be liable for pressure ulcer formation. So I cannot stress enough the importance of proper identification of the etiology of the wound. And as we're going to see, every wound is not a pressure ulcer, and we need to be very careful how we identify it and classify it in our documentation so that we do not place our facilities at increased risk. So what are some of the issues with skin assessment? Well, first and foremost, it takes a lot of nursing power and ancillary power to reposition many of our patients. Many times in the coronary care unit as well as the intensive care unit, it's very difficult with all of the tubes to reposition patients carefully without dislodging something, and it takes multiple people to do this sometimes. As we know, our nurses are very, very busy these days and have multiple things impacting them all at the same time. We also are dealing with larger patients probably than we ever have in my clinical practice of almost 40 years. It's not uncommon to have patients that are 300 pounds plus. And when you are one or two nurses trying to use good body mechanics, take care of your back, and reposition these patients, it can be difficult. At my national conference that I just attended for the Wound Ostomy Continence Nurses Association in June, I was very excited about one of the new beds that I saw there because with one finger, if a patient has slid down in the bed, with one finger you can push a button and the button actually repositions the patient back up to the head of the bed. And how wonderful that is if you think about the years that we've spent trying to reposition patients with a nurse on each side and only a draw sheet to assist us. We must be able always, though, to see and assess all skin surfaces. This is so important. Our program today will focus on Incontinence Associated Dermatitis, but there are many other causes of moisture-associated skin damage that can occur, and all of these things place our patients and at risk, and our caregivers certainly is a challenge for many of them. Pressure ulcers can be caused from pressure over a bony prominence, but today there is greater and greater visibility to this whole area brought about by a poster that has recently come out from the National Pressure Ulcer Advisory Panel. And this is a panel that has assisted us through the years with definitions for the various stages of pressure ulcers, but it really increases our awareness of medical device-related pressure ulcers, because we know that pressure can occur around all types of tubes, around trach tubes, endotracheal tubes, around retention sutures in patients, CPAP masks. So many of the patients today have sleep disorders and are using CPAP masks, and this can cause some serious pressure under it. Needless to say, leaving patients on bedpans for extended periods of time also can be a huge problem, as well as under splints and casts and that type of thing. So we always need to look at what is under these devices or the skin around the devices that may be damaged because of pressure. Let me remind you that when we're doing skin assessment, certainly the assessment looks much different on light-skinned people versus people with darker skin tones. And on patients that have very light skin, the skin is very bright, a bright red. It may glisten due to the serous exudate that is oozing out of the skin. And when you look at the skin of a darker individual, you will notice that it's not as bright red. It often presents, as a matter of fact, as hypopigmentation or a subtle red tone. So as we continue looking at the difference in moisture and pressure, sometimes this is very difficult to ascertain. And this is where a lot of confusion comes in as far as staging, as far as documentation of what we're actually seeing when we look at skin disruption on an individual. The photos on this slide are a good indication of how that can be difficult. If you look at the photo on the left, it is a stage 1 pressure ulcer. It's pretty easy to tell that that is on the sacrum over a bony prominence and is caused by pressure, whereas the slide on the right is from Incontinence Associated Dermatitis. You can tell that it's not as circumscribed. It's kind of spread out over the sacrum. Looks much different than pressure. Just as a slight refresher, pressure ulcers many times that we see in all settings, and particularly in the skilled nursing facility and home care settings, are chronic wounds that have been there for greater than 3 months duration. They have failed to heal in an orderly, predictable manner, and this is usually due to the prolonged inflammatory phase of wound healing. So you can see when you look at this wound that it's very large. It is chronic. It's been there for a long time, and these do present serious challenges to healthcare providers in every setting. It's not difficult to see here that this, again, is a very large stage 4 pressure ulcer located on the trochanter of this gentleman. This was a gentleman that I saw in home care many years ago. He had not only this type of lesion on each hip, on each trochanter, but he also had it over the sacrum as well. So he had multiple pressure ulcers. So it's pretty easy to identify that as a pressure ulcer. When you look at this photo, this is a little bit more difficult to determine. This is where accurate definition really becomes important. You can see that the skin is eroded and demacerated down onto the thighs, certainly over both inner parts of the buttocks, not necessarily over the sacrum. The sacrum would be to the left more. So you can see that this really does not look like typical pressure. Why are we spending so much time on this, and why is this really an important issue? Well, there's several reasons. First of all, we cannot accurately treat the patient if we don't understand what caused the wound in the first place. So etiology is very important. If pressure ulcers are misclassified, or Incontinence Associated Dermatitis, I should say, is misclassified for pressure ulcers, this really increases the facility's risk for litigation. Reimbursement is a huge issue in today's world. And also, when we incorrectly identify something and call it a pressure ulcer, which it is not, then this really makes our prevalence and incidence data that is really used for benchmarking nationally invalid, because we have not even identified correctly the wound that we're looking at. Also, misdiagnosis means dollars, and in today's healthcare environment, this is such an important thing. Hospital-acquired pressure ulcers are referred to in the acute care setting now as never events. They should not have occurred. And as of October of 2008, hospitals can no longer receive a higher Medicare payment related to the ulcer-specific care of patients who receive stage 3 or 4 pressure ulcers when they're under our care as an inpatient. Therefore, reimbursement is really sacrificed by the hospital, but they must continue to care for that wound even though they're not receiving increased reimbursement. In 2007, CMS, or the Center for Medicare and Medicaid Services, reported 257,412 cases of secondary stage 3 or 4 pressure ulcers. And it was estimated that the cost per case in United States dollars was $43,180. And that is CMS's data from 2009. So we know that there are many things that impact. These wounds can be serious injuries to the patients, can often lead to death. One of the problems, and this has been a problem throughout the years, is that physicians tend to see pressure ulcer detection and prevention as a nursing issue. So many times they fail to include this data in their discharge summaries. And this is the summary that is used by coders for billing purposes. So that figure that I gave you earlier may even be an underestimate. Estimated costs of pressure ulcers to the United States healthcare system, $11 billion per year. We know that when the patient develops a pressure ulcer, it increases their length of stay to 3 to 5 times longer. And patients with pressure ulcers, either primary or secondary, are discharged to skilled nursing facilities at 3 times the rate of other diagnoses. These are figures that were gotten from the Wound Ostomy Continence Nurses Society in 2011. We know that litigation can be brought against a hospital and all staff for neglect, malpractice, and elder abuse. And the awards for this litigation can be in the millions of dollars. That is one of the issues, but in addition to that, the bad publicity that that institution receives will damage the hospital's reputation, their bottom line, and the patients that trust that patients have in the healthcare and the safety of the healthcare that they're going to receive. We know that there are many sites with our internet today that patients can go on and compare various hospitals, various skilled nursing facilities, and various home health agencies to see how the one that they are looking at measures up to the national average. Pressure ulcers, of course, are reportable to state and federal agencies today, so that means that there is even a greater look at what is happening and a greater look by Medicare as well as the Joint Commission. And in fact, in long-term care setting now, the Joint Commission has again made the prevention of healthcare associated pressure ulcers a patient safety goal for this coming year. Pressure ulcer prevention programs are huge, and we're going to talk a little bit more about those and what is included in those. Now let's move our discussion to incontinence and the skin and why that is such an issue with skin integrity. We know that incontinence is the voluntary loss of urine or feces of significant magnitude to comprise a problem for the patient or the caregiver. And I can tell you as a wound ostomy continence nurse for many years, what I would have considered a significant problem is a little bit different from what the patient is concerned about and is looking at and identifying. So I think that we need to have a level of compassion and empathy when dealing with patients with incontinence, and to really be aware that to a woman in her 50s who is the CEO of a company, a slight leakage on her pad every day might be a huge issue to her, and we might not consider that such a large issue. So it really does look at what the patient defines as a problem. 13 million people in the United States suffer from urinary incontinence, and we know that urinary and fecal incontinence increases with age. In fact, the statistics prove that once a patient has urinary incontinence, within a short period of time, a year or two. Fecal incontinence certainly may become an issue as well. So this is something that increases with age, but is not necessarily a disease of old age. Women are affected twice as often as men, and I think the reason for this is very clear. It has to do with anatomy. The thing that I'd like to point out here is that incontinence is one of the leading causes of institutionalism in the elderly. Many, many patients wind up having to go to skilled nursing facilities because they're unable to deal with the issue of incontinence and all that that entails when they're living at home by themselves in their own home. The healthcare costs associated with incontinence are huge. We know that it is $3.8 billion a year for men and $12.4 billion for women, or close to that. So the average annual cost of fecal incontinence is staggering as well, and this usually costs between $4,100 per patient per year, and those are fairly recent statistics. Here, I think that those of us who have been providing care to patients for a significant period of time realize that the suffering of the patient is really paramount here. The suffering is emotional as well as physical many times because they are limited in their ability to go out into the community to partake in things like holiday gatherings at their children's homes because they're afraid that they're going to suffer an incontinent episode and maybe soil the new couch or whatever. So we really do know that this is an issue that is really long-standing for patients and a real issue. Urinary and fecal incontinence presents in many different ways, and if we look at this, we see the neonate on the left, and this is a very bad case of Candida albicans, which is a fungal infection that frequently occurs when patients have any disruption to the skin from fecal or urinary incontinence. The elderly gentleman on the left, this is from fecal incontinence, and again, you can see the skin and how much it is compromised. So let's look at some of the adverse effects of urine on the skin. We know that anytime the water is on the skin for a long period of time, it decreases the skin's hardness, if you will, and makes the skin more susceptible to friction and to erosion. And of course, when the skin is eroded, then the permeability to pathogenic specimens, species is increased, as well as difficulty in skin breakdown from the irritants in the urine and stool. And as we already talked about, occlusion can really increase this as well. Fecal enzymes, the proteases and the lipases that are in the skin frequently break down the skin barrier, and we know that that makes the transepidermal water loss increase and the pH of the skin increase as well, which means that the skin becomes more alkaline. Damage is exacerbated anytime the bile salts are present, and again, remember the role of occlusion here. Some adverse effects of the stool on skin have to do a lot of times with the consistency of the stool. There is now overwhelming clinical research to show that liquid stool is much more damaging than solid or formed stool. And can you still hear me?
Yep, you're sounding great. Thank you.
Thank you, Eric. It just sounded like it cut off there, and I wanted to make sure that everyone was still able to hear.
Oh,
the diversion of stool in the surgical intensive care unit when a fecal continence system was used was decreased from 43% to 12.5%. So I think that we can really see that just keeping the stool off the skin makes a tremendous difference. Here again, fecal incontinence, massive in this buttocks. So let's talk about the definition for incontinence associated dermatitis. It's an inflammation of the skin that occurs when urine or stool comes in contact with the perineal or the perigenital area. And this is according to Dr. Michael Gray. That's a fairly recent definition. A major risk factor for pressure ulcers anytime the skin is broken in the perineal, sacral, or coccygeal area. We know that the incidence of pressure ulcers increases following these episodes. Again, this shows fecal incontinence, and you might wonder what some of the factors are other than the ones that we've already discussed. We know that fecal incontinence places the skin more at risk. Certainly the frequency of incontinence is to be closely monitored in these patients. If patients have poor skin condition to begin with, or if they have hyperthermia, we know that with temperature, if you think about some of the patients that you might have seen in the intensive care unit, frequently these patients that are very, very diaphoretic, their skin breaks down very, very quickly. So moisture, certainly coupled with fever, as well as alkaline pH, is a big issue. Let's look a little bit at the pathophysiology of incontinence-associated dermatitis. We know that more research is needed to be able to really clearly identify all of this, but we know that the skin changes occur when the skin has prolonged exposure to urine or feces. And the double incontinence is even more of a disaster than being incontinent of urine or stool alone. What happens is when the patient is incontinent, this stimulates an inflammatory response on the skin. The inflammation is increased, as well as edema and erythema, and this increases the transepidermal water loss. More water is lost out the body from the inflamed areas. This increases the risk of maceration and decreases the effectiveness of the moisture barrier of the skin that we were talking about. Maceration increases the skin's pH from an acid mantle to a more alkaline area. So we know that bacteria from fecal incontinence may also convert the urea that is in the stool that is in the skin from urinary incontinence to ammonia. So if the patient has mixed incontinence, they are certainly at greater risk for infection from microorganisms, as well as the things that we have already discussed as far as the pain associated with inflammation, erosion, the secondary infection that can occur, whether we're talking about infants or adults. This can be excruciating for patients. I had a patient once tell me, Mary, if you can imagine what it would feel like to slide down a banister of razor blades and land in a tub of alcohol at the end, that's what my skin feels like. And I think that's pretty dramatic. So there's certainly a lot of pain and discomfort for patients that experience this. If we look at the pathophysiology, I'd like to point out a research project that Bliss and Associates did and published in Nursing Research in 2006. They looked at 10,215 nursing home residents' medical records, and they were able to correlate perineal dermatitis significance as it related to the type of incontinence that the patient had, or whether it was urinary, fecal, or double incontinence. What the results of this study showed is that there was no significant factor for developing incontinence-associated dermatitis for urinary incontinence alone. Double incontinence, for instance, urine and stool, had a very strong significance, but fecal incontinence alone had the strongest significance for developing perineal dermatitis among the 10,000 records that they were able to analyze. So I think that really shows us where our attention needs to be. So let's take a few minutes to really look at incontinence-associated dermatitis versus pressure ulcers. We talked about the importance of etiology, that incontinence dermatitis is not necessarily over a bony prominence. Pressure ulcers are caused by ischemia to the area and usually occurs over a bony prominence. In incontinence-associated dermatitis, as we've been able to see from the slides that we've looked at, there's a diffuse rash. It's not well circumscribed like it is in pressure ulcers. It can be bright red or red in incontinence-associated dermatitis, and in pressure ulcers, it may be red, but it also may be a purplish bluish color. And this even relates to a new stage of pressure ulcers. Depth is really, really important because in incontinence-associated dermatitis, the wounds are partial thickness. That means that the area is limited to the epidermis and the dermis, and it is two-dimensional. In other words, if we were to measure the wounds, it would be length and width only. There would be no depth associated with these. Whereas in pressure ulcers, they can be partial, but they also frequently are full-thickness wounds, and they extend through the dermis into the subcutaneous layer and structures under that many times and are three-dimensional. So those are really going to be the wounds that are going to have a depth. So if you see necrosis and if you see depth in a wound and it is located over an area of pressure, then you can be pretty safe in believing that that is a pressure ulcer. In incontinence-associated dermatitis, there is usually no necrosis, and of course in both of these, patients have a remarkable amount of pain and itching from the skin breakdown. Important to note that we do not use the National Pressure Ulcer Advisory Panel pressure ulcer staging system to describe incontinence-associated dermatitis. That's really important to remember. Let's go on and look at some of the goals of perineal skin care. Michael Gray says it very simply. We want the skin to be clean and we want it to have minimal exposure to the irritants. And so I think that that's really important to remember. Sometimes we can see the damage with our eyes alone, but the epidermal water loss is very difficult to ascertain only by looking at the skin. So many times there can be pain and significant skin involvement when we're not able to see it with our eyes. Inspection is so important because that leads to early intervention. And we want to discuss three things: cleansing, moisturizing, and protecting. The most important thing is to protect the skin. And when we talk about skin moisture barrier ointments, that's what we're talking about, is protecting the skin. We want to use emollients to hydrate the skin in order to reduce the risk of skin damage. Anytime that skin is dry, it can break or fissure, and this puts the patient at increased risk for pressure ulcer development. When do we really moisturize skin? After a bath or a shower. That's the most effective time. Protecting the skin from exposure is really important because we know that once the skin is broken, that moist skin does not glide very well across linens and further damage can occur. So let's look at cleansing, moisturizing, and protecting. We know that frequent bathing is not what is done anymore. In fact, patients tell me all the time that they can be in the hospital for 3 or 4 days and never receive a bath. I find that a little bit difficult, but I know that our priorities are changing, and bathing is frequently not one of those. If we do bathe patients, we want to be very gentle, make sure that we do not scrub, try to use products and cleansers that keep the acid mantle of the skin around 5.5. Towel drying has been discouraged because we know that that causes increased roughness on the skin, and many of the surfactants that we use to remove dirt and bacteria from the skin can increase the transepidermal water loss as well. Moisturizing the skin, humectants have a large component to our moisturizing factors these days. The lipids that is in that intracellular layer of the stratus corneum that we talked about is the reason that we need to moisturize, and that helps replenish those daily after bathing again, and making sure that we use non-sensitizing products. Emollients are also frequently used, and emollients differ from other types of moisturizers. They're usually oils. They are used to make the skin soft and smooth. Humectants are usually glycerin-based, and they actively bind the available water in the epidermis to the epidermis. That's the reason it's so important to replace them after patients have had their bath. Protecting the skin, skin protective barriers should act as the moisture barrier. They actually protect the skin from the deleterious effects of anything that the skin comes in contact with, whether it's urine or stool. We want to maintain the hydration of the skin and really slow that transepidermal water loss out of the skin. It's important to choose products that avoid maceration if they're on the skin for extended periods of time. Skin moisture barriers come in liquids. They come in sprays, lotions, creams, pastes, and ointments. They all are a little different. It is important to always look at the manufacturer's recommendations for use for these products. Some of them, particularly the skin sealants, may contain alcohol, and if they do, would severely cause pain to the patient if you're putting them on denuded skin. So try to look at some of the no-sting skincare products that are available. 3 types of skin protectants that are frequently used are petroleum, dimethicone, and zinc oxide. All of them are very, very effective. I find the big difference in these 3 products to be the ability to be able to assess the skin underneath without fully removing the product. Because if you use zinc oxide, for instance, it's mixed with a cream or an ointment, it's difficult to get off the skin to really see what's happening to the skin underneath. And sometimes aggressively trying to remove that causes more skin damage. So my personal preference is for the dimethicone products because they're silicone-based, they're clear, and you can really look at the skin underneath. When you compare them, when you're comparing skincare protectants, make sure that you always look because you want to not only achieve good protection with them, but you also want to avoid any maceration with them. So some are very good at hydrating the skin, some are very good at protecting the skin, and what you really want to do is find the one that's going to jointly do both of those things for you. All-in-one products are wonderful. If your facility has the ability to use these, it's tremendous because it saves nursing time. It decreases the discomfort for the patient because you don't have to rub and wipe many things on the skin. It's just a one-step application. They're available as cloths and spray-on applications, and they're very, very nice. When we look at a skincare regime summary, then, what we really want to do is cleanse and protect the skin, use products that wick the moisture away from the skin, prevent any secondary infection, and really examine the skin frequently for signs of skin damage. Skin care training is of paramount importance, and it should include all levels of nursing staff. When I was in clinical practice as a WOCN, I was included in all of the orientation programs to talk to the staff about skin care and prevention of pressure ulcers. And I think that training is very, very important. If you have a wound ostomy continence nurse in your facility, make sure that you include her in prevalence and incidence studies for pressure ulcers so that you can make sure that your data is accurate for benchmarking. And of course, complete and accurate skin assessments are always necessary to be able to differentiate between incontinence-associated dermatitis and pressure ulcers. So in a management program for incontinence, we certainly want to protect, cleanse, moisturize the skin, but in addition, we want to include other things. And your program should really look at dietary and fluid management, bowel training, or stimulated defecation programs, if that is possible at your facility. Look at the patient and the functionality of the patient. Is the patient able to get up and to ambulate with assistance to the bathroom? If they can, it certainly is preferable to doing that to having the patient void in bed. Prevention and care begins then with a clear diagnosis. As I mentioned, look at the functional status of your patient. Really look at the level of incontinence. Is it light, moderate, or heavy? And try to protect the skin from irritants. When we look at incontinence products, there are so many on the market. There are many, many companies that provide these. They come as liners and pads. They come belted, which are very nice. You know, we talked about the role of occlusion, and that increases the relative humidity and the pH. So if you're using like a belted incontinence garment, it really allows the air to flow through the garment. There are products that are specifically designed for care at night. Overnight fitted briefs, these usually have a little bit higher capacity than other types of briefs or pads. So there are many, many things to take into consideration when you're trying to help patients with pads or protective undergarments for incontinence. Also be aware that some incontinence garments do not support fecal incontinence. In other words, they're only produced for urinary incontinence, so you want to make sure if your patient has fecal incontinence that you pick the appropriate pad. So the other considerations that you might want to look at is, what is the garment made of? Is it going to leak? Fit is so important, so you really need to be careful to measure your patient correctly for these. If it is something that the patient is used to using and they're familiar with, that certainly helps a lot in making them feel better about using products. So really assessing the incontinence patient's needs, toileting them every couple of hours if you could. We talked about being empathetic. These people have so many issues to deal with that they really need to have someone that is understanding and tries to help them problem solve rather than someone that really makes them feel worse about their incontinent episodes. So it's really important to work as a team with the patient to make this a less burdensome issue for everybody. We know that our team comprises many, many people, our skilled nursing facilities, our ancillary staff, our physicians, our nurses and nurse practitioners and specialty nurses, but always remember to include the patient themselves if they are able to be involved in these decisions, as well as their caregiver if caregivers are working with them. It will make our job so much easier if we have the buy-in of the patient and the caregiver. that concludes our program for today. And I think that Eric is going to be taking some questions at this point.
Great. Thank you, Mary. That was excellent. That was really, really good information. I can't get that image of sliding down a banister of razors and landing in a puddle of alcohol. I'm not going to be able to get that out of my head. So if you do have a question, please type it on the question box to you right of your screen. We do have some questions here. Can we get a copy of this presentation? Yes, you may. We'll post it on our community site after the presentation is over. Also, the recording will be posted as well. So Mary, do you have any suggestions on ways to spot stage 1 pressure ulcers on darker skin?
Well, I think if you look back in the slides, that slide that we showed, certainly this is an issue, and it's an issue for wound ostomy continence nurses as well as other nurses in practice everywhere in every setting. It's much more difficult to tell redness on skin that is of a darker color. I would suggest also that you always try to feel the area. I have some colleagues who are saying that they have been recommending to nurses to remove gloves so you could really feel warmth with your hand. It's a little bit difficult to feel that through the gloves that we wear. However, most of our institutions still require us to do that. So you're certainly going to have to look at your policies within your institution to decide about that. But I'm suggesting here that we need to be not only using our eyes and looking at the skin of the darker skinned patient, but that we need to use our other senses as well. Feel, for instance, to see if we can feel any increase in temperature in that area. Because redness is very, very difficult to ascertain on a darker skinned person.
Great, thank you, Mary. Before we take the next question, for those of you attending the webinar, you can qualify for one CE contact hour. Just log on to capitalnursingeducation.com and then click on register. So Mary, we have a bunch of questions here. We're going to try to answer as many as we can. However, we may have to answer them offline as well. So Mary, do you have any recommendations for over-the-counter skin protectants / moisturizers?
Well, I tell my home health nurses all the time because, you know, when you're working in home health, as I did for many, many years also, you know that sometimes you're limited to either what you have in the trunk of your car or what your patient has in their medicine cabinet. So I think the important thing, remember when we talked about petrolatum, petrolatum is a moisture barrier protective ointment. And so I would certainly, I would guess that most patients are going to have something like petrolatum in their medicine cabinet. So I would certainly look there first until you can get something ordered to use, because that will do a very, very effective job of protecting the skin from moisture and stool.
Great. A question from Marion. I think you just answered it. What barrier or brands do you recommend? Is there any combination that is more effective than others?
Well, now are we talking about moisture barrier ointments or are we talking about moisturizers?
Barriers.
Moisture barriers. All right, all of them are a little bit different. Having worked for 2 major national companies, I can tell you everyone touts their skincare line, and very honestly, they're all very good. I think to keep in mind that you want something that is non-sensitizing, so something hopefully without a lot of fragrance. You want something that protects very, very well, and something that does not macerate the skin if it's left on for an extended period of time. I think that the skin care programs that I am familiar with as a WOCN, and I've worked with several other companies, as a clinician, I think all of them have very, very good skin care lines. The important thing is when you realize that the patient is incontinent, to begin using something then, not to wait, because once the skin is broken down, it's going to be a very difficult thing to turn around.
Great. Thank you, Mary. In what situations do you see IAD and pressure ulcers together in the same area?
That would be in the immobile patient. We know that the National Pressure Ulcer Advisory Panel has looked a lot at repositioning patients and how often do we reposition patients. Is it every 2 hours? Are there patients that need to be repositioned every hour? That is still very controversial. It's very up in the air. We keep looking at this as we've been looking at it for the last 20 years. So I'm not sure that an answer is forthcoming very quickly. What I would say is if the patient cannot be repositioned for whatever reason in a reasonable period of time, and they are incontinent of urine or stool, that's going to be the patient that would be at increased risk, both for incontinence-associated dermatitis as well for pressure ulcer development. And the pressure ulcers, most usually on those patients, will occur over the sacrum or the coccygeal area.
Great, thank you. Question here, how does zinc cause maceration? I had the understanding that it was a better barrier than others.
Am I hearing you correctly? You're saying zinc causes maceration?
Yeah, I don't remember you saying that.
No, I don't think that I said that.
Yeah.
I would certainly be not correct if I did say that or lead anyone to believe that. No, zinc oxide, I think the discussion was about the differences between petrolatum dimethicone and zinc oxide moisture barrier ointments. And I made the remark that my personal preference is the dimethicone because it's, once you apply it, it is like a thin moisture barrier ointment. It keeps the stool off of the skin, but it's clear. You can see the redness or the broken skin underneath. Therefore, you can tell as the skin is getting better. Whereas with the zinc oxide, and there are a number of zinc oxide products on the market, some of them are white, some of them are pink. They are very, very effective as moisture barrier ointments and certainly should be used. The tendency with a lot of times our ancillary staff or our certified nursing assistants working with incontinent patients is to try to get all of that off in between incontinent episodes. And in trying to remove a zinc oxide, they can truly do a lot of damage to the underlying skin as well, trying to scrape it off. So the best thing is just to pad off whatever fecal incontinence is there, get off as much of it as you can. Don't worry about getting the zinc oxide off. Just put another layer of zinc oxide on top of it and give that skin underneath an opportunity to heal.
Great, thank you, Mary. We only have time for a couple more questions. How is IAD coded in ICD-9 and ICD-10? Yep. Do you happen to know that?
You know, I'm not sure. I don't want to mislead anyone. That is certainly a question that needs to go to a coder. Mm-hmm. And as I indicated, one of the biggest problems for us as practitioners is being able to accurately identify whether it's incontinence-associated dermatitis or whether it's a pressure ulcer, because they are coded very, very differently. And many times this is not picked up in the in-hospital documentation. And if physicians' progress records or discharge summaries are looked at to get the status, sometimes it is not reflected in there either. So I'm not sure how incontinence-associated dermatitis is coded. in the ICD-10s. I'm not sure of that. That question needs to go to a coder.
Great, thank you. We have time for one more question, and I apologize for those of you who are asking questions and we can't get to them. What products can we use now that balls, castor oil, and trypsin products are off the market?
Well, basically, those products, when they were released with the idea that they stimulated the circulation to the skin somewhat so that the skin could be healthier and have more blood supply to it. Granulex, I believe, is probably the product they're referring to. It was a standard in incontinence care 20, 25 years ago. As you indicated, it is no longer available. So I think that what we really need to do is look again at the three things, the three components of a skincare regime: cleansing, moisturizing, and protecting. And if we protect with any of those moisture barrier ointments that we talked about, we're going to be in really, really good shape. There is, to my knowledge, nothing that is the same as that product that is no longer available.
Great, thank you so much. That's all the time we have for questions. If you have a question, you can ask it at marketing@shieldhealthcare.com, and we'll get your questions answered. I want to thank Mary Sears for a really great presentation. That was probably the most popular webinar we've ever had, so thank you so much for doing that. A couple of housekeeping items. Our next webinar will be on Wednesday, September 16th, Home Tube Feeding, How to Troubleshoot and Manage Common Complications with our corporate RD, Amy Carrera. And again, this webinar is recorded, so if you missed anything, feel free to log on to our shieldhealthcare.com/community site, and we will have the PowerPoint and the recording available to you. Thank you, everybody, for attending this webinar. Have a great afternoon.